So let me get started on the mental health training. And just so you know, this is, like I said, a high-level overview of the Mental Health Act. And it basically is an act. An act is a framework or a legislative framework that we have to follow. But an act doesn't tell us how to operationalize things. It doesn't give us the steps that we need to take to make it work. That's something that's done separately. And just so you know that there are working groups or working group involved in looking at all the key areas that need to be available for us by September 1st, so that there's some answers to some of the operational type questions when the Act comes into force. So again, today is going to be about the Act and the framework. It's hard not to ask questions about policy and operationalizing things, and that's okay. Ask them. We may have some answers already. We may not, and just so you know, if we don't have them, we are taking them down and we are following up with the working group to make sure that, because you guys are in the field, so you understand the practicalities of putting an act into play. So that's why it's important to have those questions raised and that dialogue. So I'm going to ask a question if everybody's okay, and if I don't hear anything in a few seconds, we'll start with the training. So how is everybody okay with this? Okay, can I have the slides? You're gonna lose there. You've lost my face. Now we're into the slides. So if you want to flip along to, this isn't moving it. Oh. Oh, okay. Great. There. Throughout the day too, we're going to take a break this morning at some point when it's appropriate. We'll have a break at lunch, and then we'll work through, have a break in the afternoon too, so that you know. So introduction, Mental Health Act training agenda, introduction to the Mental Health Act. Like I said, we're going to do an overview of the Act, comparing the current and the new Act a bit, and the regulations that form part of this Act. So, and we're looking very closely at the principles under the Act and patient rights, because that is a really key piece that has been added to this Act. We're going to discuss the roles for professionals, health professionals, administrators, and RCMP. As nurses, you're going to see that there's an addition there in this Act for you. And I think it's a really good addition, actually. As a nurse myself who's worked in this area for a long time in the North, I think it's a very good, a good thing that's happening here. We're going to talk about the involuntary admission process, timelines that are identified in the Act and how they have changed from the current Act. We'll look at apprehension, conveyance, and detention, short-term leave, which is new, different, but it's actually, again, something that we want to cover as we talk through today. We're going to discuss transferring of patients within the NWT, outside the NWT, and from another jurisdiction into the NWT. We'll look at treatment decisions, including competencies and consent to treatment and substitute decision makers, which we have in our current Act, but again, we'll cover that. But two of the new pieces that we're going to be covering is assisted community treatment, which is new to this Act, and that also includes a community treatment plan that supports it. And another new addition to the Act and to our world of working in this area is the Mental Health Act Review Board, which I think is a very exciting step forward. So we are bringing this Act into the current best practices and thinking across Canada. The current Act is now 30 years old. It was came into force in 1988. So we're making up for some changes in time. So I asked you why we need a Mental Health Act, and everything you said was exactly what the reasoning is for having it in Mental Health Acts. We need to help, excuse me, we need to have a legislative framework that guides the treatment, care, and protection of individuals living with a mental disorder. So this Mental Health Act is intended to provide direction and guidance on how and when a person can receive treatment, assessment, care for their mental disorder. It is intended to identify who can be admitted to hospital, when they should be admitted, and how the person would be admitted while making sure their rights are protected. This Mental Health Act is going to outline how to balance the right of the person living with a mental disorder with their need for care and treatment and the safety of others, and it sets out processes that must be followed and safeguards to ensure people living with a mental disorder receive care and treatment in the least restrictive manner. And we'll talk about that when we talk about the principles, because that's one of the key principles. Another thing to note is this Mental Health Act does not have any age limits. It can be used to help children, youth, adults, and elders. So just a bit of background information about this act. Bill 55, the Mental Health Act, replaces the existing Mental Health Act. And it's because like I said, the current one that we're working with until September 1st was in force in 1988. It's a bit out of step with national and international standards. Best practices and mental health philosophies of care have changed a lot since 1988. This Mental Health Act has been written in a recovery, a patient-centered focus. So it's looking at recovery, and just recovery-oriented approach to care. So this act is really reflective of current thinking and current practice. Bill 55 was passed in 2015 on October the 8th, and again, it focuses on individuals living with a mental disorder. But in order to have this bill created, there were 2 years of consultation that occurred, and through those 2 years of consultation across the North, there were 52 recommendations made that helped guide the development of this legislation. So some of the areas that were incorporated in the Act were improving patient rights for voluntary and involuntary admission, setting timeframes for mandatory reviews. So you'll see very clearly this Act has some very different timeframes and timelines, but they're very clearly stated. So there's no room for, well, what does that mean? It's very, the timelines are really clear. It was actually another recommendation was a transfer, leave, and discharge with increased supports for transitions and improved patient care through case management practices. That's been identified in the Act, and from that becomes assisted community treatment. And this means that patients are supported to live in a community as an involuntary patient, and we'll talk about that more fully later in the training, because it's a topic that warrants full discussion. The NWT Mental Health Act Review Board is also new, and the Review Board provides external review for appeals. And this again provides better protection for patient rights. Along with the Act, 6 regulations were finalized in February of this year, and they provide information for implementing the Act and include the prescribed forms under the Act. They are consistent with the Act and within the regulating power described in the Act. And as I've said, this Act will come into force September 1st. So it's really nice that you guys are taking this training now. You've got some resources that you can go back and look at so that by September 1st, it won't be a new document to you or a new Act to you. It won't come as a surprise. You're getting forewarned and prepared for this. So the Mental Health Act regulations, just briefly to discuss all 6 of them. The first one is designation of facilities regulation, and that means a facility designated by the regulations for the examination, care, and treatment of a person with mental disorder. So there are 4 facilities named in the designated facilities, named as designated facilities under this regulation. They're Fort Smith Health Center, Health and Social Services Center, Hay River Health Center, Inuvik Regional Hospital, and Stanton Territorial Hospital. And just so you know, these are the same designated facilities that are in the current Act. And the reason these 4 facilities have been named as designated facilities is because they do have the resources to properly examine, care for, and treat people with a mental disorder. But as you're aware, Stanton is the only facility with an inpatient psychiatric unit and full-time psychiatric staff. So Stanton tends to take most of the people that have a mental disorder. But that doesn't say that, and doesn't mean that Fort Smith, Hay River, or Inuvik, there aren't times when they can actually care and treat a person with a mental disorder in any one of their facilities. And a person would be admitted to one of these 4 designated facilities for care and examination and treatment unless they require services that can't be provided. And then, of course, arrangements can be made to have the person transferred outside of the NWT for care and treatment. We'll talk specifically about transfer of patients a little bit later. So the next one, the Mental Health Act General Regulations. The general regulations expand on the processes required to notify patients of their rights under the Act and the requirements of placing limitations on patient rights. This act is very clear about when patient rights need to be given their rights, and I think that that's an area that has improved vastly, because I think it's an area that in current practice we may or may not do very well. Also, the general regulations: when a treatment decision certificate or a certificate of mental incompetence, certificate of involuntary admission, or renewal certificate is canceled. So here you're starting to hear some of the names of the certificates that you'll find in this act that have been developed to support this act. Or when a certificate of involuntary admission or renewal certificate expires, the regulations outline when notice must be provided, information regarding expected date, time, and release, and is included in the notice if applicable. The general regulations also discuss administrative matters such as the designation of medical practitioners as attending medical practitioner and delegation of tasks assigned to the directors. So an attending medical practitioner in this act is a member of the medical staff of a designated facility where the patient is admitted and has primary responsibility of care for the patient. And it's important to note that the definition of health professional now includes nurse practitioners and registered nurses. The general regulations also talk about filing of certificates and compiling a patient registry of involuntary patient data as described. So again, back to that administrative matters. The apprehension, conveyance, and transfer regulations, for this act, along with a peace officer who is a member of the RCMP, we also have an other authorized person who can convey someone. There are a number of sections in the act identified that of the regulations where an other authorized person can be asked by a medical practitioner or health professional to convey a person. Other authorized person has been defined as a person engaged in providing Medevac services, including an EMS provider. So this is new, and so depending on the person or the patient, who will convey a person or patient is determined based on their condition, the risk of harm posed by the person to themselves or others, and any other significant factors. But you do have an option for conveyance, because as we know, sometimes asking an RCMP could just escalate the situation. So there are some abilities to convey with an other authorized person. This regulation also has a section that provides for the extension of time to convey a person or involuntary patient to a health facility by an additional 72 hours, should there be delays in transport. The initial time is 24 hours. Also, if you want a section 7, subsection 2, in case you're interested in going to that regulation, describes appropriate locations where an individual may be detained should there be issues with transportation to a designated facility. And I know that you've all been faced with bad weather, planes going out, planes being canceled, those kinds of things. So basically, this gives you appropriate locations where they can be detained. And also in that same regulation under section 8, it describes the requirement to notify the director of the designated facility about these delays. The last piece that's in the apprehension, conveyance, and transfer regulations that I want to point out to you is that any use of restraints needs to be recorded, including the type of restraint used and the reasons for the use of the restraint. And restraints are always a big discussion area in this field of work. So we also have assisted community treatment regulations, and these provide information about the notification requirements, such as when there's intention to initiate assisted community treatment, when assisted community treatment is started or has expired, and prior to the expiry of involuntary admission. It identifies what is required if an involuntary patient is transferred to another facility. It identifies what happens if there are any amendments to the community treatment plan, and it requires the designation of the medical practitioner who is responsible for supervision of the community treatment plan. And again, as I said, we'll talk specifically about assisted community treatment this afternoon. Our last two regulations, there's the review board regulation, and this describes the board composition. It provides information about the review board's role. It addresses hearing requirements that they must be held within 14 days after receipt of the application, after acceptance of the application. It identifies when review panels are due. and their orders, I mean, are due within 48 hours after the completion of a hearing, and it outlines the required information to be contained in an annual report. And the last regulation is the forms regulation, and it outlines the required 29 forms and their content. I'm going to pause there for a second to give everybody a chance. If you have any questions about those regulations, feel free. All right, we'll move it along to key changes to the Mental Health Act. So as there's some areas that we said that have changed, that are the same. So criteria for involuntary admission is much the same. Same with the designated facilities. But 4 areas that have really become a good focus in this act are patient rights, leave provisions, director of a designated facility, and creation of a Mental Health Act Review Board. And we'll be covering all of that throughout the day. So the key elements of the Mental Health Act, and again, as I said earlier, it's legislation that supports people living with a mental health disorder. There are comprehensive measures for protecting the rights of persons with a mental disorder and those acting on their behalf. These have been written into the Act. So we're looking at the safety of patients, families, and the public. That's reflected throughout the Act. This Act is important to ensure people living with a mental disorder receive appropriate treatment and care in a timely manner. So this Act actually, as we said earlier, modernizes the mental health legislation to reflect current best practices and legislation elsewhere in Canada and internationally. It definitely reflects the cultures and traditions of the NWT, and that came out through the recommendations, and then that was reflected when they wrote the Act. It recognizes current privacy provisions and trends in mental health services, such as community treatment and the ability to appeal to the Mental Health Act Review Board. It includes comprehensive measures for protection of rights for persons with a mental disorder and those acting on their behalf. It also ensures the safety of patients, families, and the public, and it improves the inefficiencies in response to gaps in the current system. So one of the key elements of this Act that I think is an important piece is the principles of the Mental Health Act. They are a set of principles that are designed to provide guidance to all persons involved in the administration of the Act, and it will help in your decision-making and actions in relation to care, support, and treatment provided under the Act. So the principles are designed to inform decisions, not to determine them, and it's important to apply them in the context of the situation, such as what is in the best interest of the patient at that moment in time, how they can be cared for using the principles as your guide. And I don't think these principles are very much different from the principles of care and practice that most of you do that provide in the communities. We look at these principles. If you want to look at them in your Act, if you want to go to the cross-reference, go to section 2.1. And what it says there is there are to be no delays in making and carrying out decisions that affect a person under the Act. I think all of you work under that principle now. There is respect for the person's culture, language, and spiritual or religious beliefs. Health professionals will consider the safety of the person living with a mental health disorder and others. The least intrusive approaches to treatment are used when actions are taken or decisions are made, considering the safety of the person and others. And again, that's referring to the use of physical and chemical restraints being documented by health professionals and by peace officers or other authorized persons if that occurs. The person's relationship with their family and community and their involvement in the person's care is important and will be considered when planning care and treatment. A person subject to the Mental Health Act will make their own decisions to the extent they can, and the person's privacy is respected. So, patient rights. So by following the Act, the patient is protected in an appropriate and lawful manner. The Act identifies what the patient's rights are and addresses how and when their rights are made known to the individual or appropriate others, such as a substitute decision maker. So a health professional who issues a certificate under the Act that authorizes the detention of a person must provide that person or patient with specific information about their rights, both verbally and in writing. So before I go any further, I need you to understand these definitions. A person is an individual experiencing a mental health emergency that is being held under the Act but not yet admitted to a designated facility. Whereas a patient is an individual experiencing a mental health emergency admitted to a designated facility. So that's why I'm using both terms, because we have both patients and persons in this. So there are two sets of rights: the rights of a person detained under the Act before being admitted, and the rights of involuntary patients. So key aspects to consider with respect to patient rights include protection of the person's rights are consistent with treating the person respectfully and as an individual. People must be informed of their rights as soon as they are detained involuntarily. Rights must be presented in written form and verbally in a language and manner they understand. So again, that means that you may have to use an interpreter. And people and patients are provided with information about their rights specifically when the following forms are issued. So when there's a Form 2, Certificate of Involuntary Assessment, a Form 3, Certificate of Involuntary Admission, a Form 4, Renewal Certificate, or a Form 13, Cancellation of Treatment Decision Certificate. You would also make sure the person was informed of their rights if you're unsure that they understand the rights. So again, if you have somebody come to the unit, they're quite psychotic at that moment, when they start to settle would be the best time to give them their rights, because they wouldn't be understanding it at that initial admission. Any person detained under the Act has the right to know why they're detained, why the certificate was issued, and under what authority. They have the right to know they can submit an application to the Mental Health Act Review Board to request cancellation of a certificate, and they have the right to consult with and receive legal counsel from a lawyer in private. And again, we have had discussion from some of the other groups, and that just means that you would provide them with a phone number for legal aid and a phone where they can make a call in a private area. You don't make the calls for them, and you don't have to. So if you have in your package the poster called Patients, the Northwest Territories Mental Health Act, patients under the Mental Health Act have the right to, you can see the rights on the slide here, but you can also see them on the poster. And this poster is going to be a poster that you need to display so that people have that information available to them. But every involuntary patient has the right to know why they're in hospital. They have the right to identify a person to be notified of their involuntary admission. They have the right to access to their substitute decision maker if that's applicable. Have visitors, use the telephone to write, send, and receive correspondence. Not to be deprived of any right or privilege enjoyed by others. They have the right to consent to or refuse treatment unless a substitute decision maker has been appointed. But as you can see, there's some of them there that have a star behind them, and those are the ones that can be restricted. And they are restricted, be limited if the medical practitioner believes, based on information either directly observed or provided by the patient or others, that there is a risk of harm to the physical, emotional, or mental health of the patient or another person. Again, you would keep revisiting those restricted rights, and you would actually ensure that you made unrestricted them or made them full rights when and if the time is appropriate. So if the patient's rights are limited, the attending medical practitioner must provide the patient and the substitute decision maker verbally and in writing an explanation of the limitations and why, length of time, and the right to apply to the review board. So there is an opportunity there to restrict those rights, but you would have to make sure that they have that information. And you would continue to reassess that information. At the bottom of that poster, if you're looking at the poster, or in this slide as well, is the same. It has your doctor or health professional must is the lead-in statement. And so there's specific obligations with respect to the rights of a patient or person under the Mental Health Act. So you allow the person or patient to communicate with a family member if there's a delay in getting them to the designated facility. You allow the person or patient to identify a person they would like to be made aware of their admission. You would assess and examine the patient regularly to ensure they still meet the criteria as an involuntary patient under the Act. And you would allow the person a second medical opinion if they do not wish to be discharged. So these posters are going to be displayed in all health facilities in a place that people can see them. And all patients, when given their rights, there is a wallet card that will be sent to you as well as part of your package of resources that will come to you. And the department is looking at, right now they're in French and English, but the department is looking at having them translated into all of the official languages so that at least you have one piece of information that is in their languages. So remember, you're to repeat the rights if you believe that the person does not understand or if they need a reminder. So this is stronger than our current act. We really have clearly identified when patients' rights are to be explained to them. Any comments about that? About the director of a designated facility. So as you're aware, delegates are very much a part of our current act, and this they no longer exist under the new act. And this is partly due to the fact that that faxing forms to and from a delegate office is inefficient and really not good practice with respect to privacy of information. And also the delegates didn't work within the hospital setting. So the delegates in this act, for each of the 4 facilities, the director who is responsible for the overall implementation, administration, and compliance of the legislation is within the respective designated facilities. So your directors of the designated facility are in Hay River, it's your CEO, and in Fort Smith, Inuvik, and Stanton, it's your COO. So there are some roles and responsibilities that the directors have for ensuring each patient is provided with professional services, care, and treatment that is appropriate to the patient's condition. There are some responsibilities they have sole responsibility for. These are duties that cannot be performed by anyone else. There are shared responsibilities, powers, and duties that each director of the designated facility has that can also be performed by medical practitioners or health professionals. And then there are responsibilities that the director will be held responsible for but can be delegated to 1 or more persons. So if you could go to your Mental Health Act guide to the Mental Health Act, to Appendix 1 on page 47 and 48, you will be able to see a summary of the roles and responsibilities of the directors. So I'm going to give you a few minutes to read through the role with respect to the Mental Health Act Review Board too. They must notify the review board of involuntary patients that have been admitted for 6 months without prior review by the review board. So if somebody has been an involuntary patient, they have not come to the attention of the review board in that time frame, the director will actually notify the review board that there's somebody that needs to be seen by the review board. If everybody's doing okay, we'll move on to the health professionals' roles and responsibilities. So under the current act, only medical practitioners are able to examine and assess a person to determine if they should be detained for mental health care and treatment. But under this act, health professionals have been defined as a psychiatrist or a medical practitioner other than a psychiatrist, a psychologist, nurse practitioner, and registered nurses. And that we're hoping that through that allowance, and the Nursing Association has been involved in the discussions as well, that it will allow more individuals to receive an initial examination in their home community. So they are allowed to do Form 2, which is a certificate of involuntary assessment. We'll talk about the differences between the Form 2 and then actually an admission, which is actually still a medical practitioner that needs to do that. But other than the examination, which is the certificate of involuntary assessment, health professionals also are responsible for clinical functions related to admission, treatment, support, care, discharge, and community treatment. No different than what you do now. Support patients under assisted community treatment, provide information to clinicians and family members, and also report to review panels. Another person that's been identified in the Act and has some specific roles and responsibilities are the peace officers. So under the current Act, a private person or a psychologist or peace officer, which is the RCMP, can apprehend a person and bring them to a medical practitioner or a hospital for assessment. But under this Act, technically, unless the person is willing to come with your family member, a peace officer is the only person who can apprehend a person to bring them to a health facility for an examination by a health professional. They have the authority to both apprehend and convey a person under the Act, and the authority to detain and control a person for those purposes. So again, I would just want to stress that it's still possible for a friend or family member to bring a person if they're concerned about, and the person is willing to come with them to a health facility for an examination. That doesn't have to be explicitly stated in the Act. But as you're aware, people suffering from a mental disorder or experiencing a mental health emergency may be aggressive. Therefore, apprehension by a friend or family member is not necessarily encouraged, because you don't want to put anybody else at risk. If a friend or a family member believes that the person is suffering from a mental disorder and it is in their best interest to be examined by a health professional, they can call the RCMP. If it's not in an urgent or emergent situation, they can apply for a court order, or if the risk of harm is low, again, as I said, they can bring the person to the health center. In communities without RCMP, the process for apprehension remains the same as under the current act. Do I have a question from somebody? I heard.
Yeah, just in here, just wondering, so previously the RCMP would bring somebody in on was called Form 5, where they had to be brought in for assessment, but it didn't have to be us telling them to bring it in. Like a family member could call and place a report, they would fill out the form, bring the patient in for assessment. Is that what a Form 27 is, or is that us telling them that they have to come back?
No, okay, so no, the Form 20, there is no form. So basically, a family member can call the RCMP and give them their information, and then the RCMP can apprehend that person and bring them in as long as they believe that there's reasonable grounds to do so without a form, no.
Yeah, so in the current act, they need to complete the Form 5, which is their summary statement. It's their facts with the reasons why they felt they needed to bring that person in. In the new act, when it rolls out, RCMP still have that same authority to do that, but they no longer need to fill out a piece of paper. They would just verbally communicate those reasons to the health center staff.
And they have been involved in all of the discussions with the development of the act. And the Form 27 that you're talking about is specific to asking an involuntary patient who is subject to an assisted community treatment certificate to attend a mandatory assessment. So that's a different form. They can apprehend a person with an apparent mental disorder. They can transport them to a health facility for an examination. They can also assist with the apprehension and conveyance, like taking a person under Form 2 to a designated facility. They can apprehend and convey a person under an order for examination by a justice, or if they have reasonable grounds to believe the person is suffering from a mental disorder. They have a role of conveying people being transferred within the NWT and outside the NWT, and apprehending and conveying a person from outside the NWT back to the NWT. They can apprehend and convey a patient released under assisted community treatment who is required to return to the facility, or if they have grounds to believe the person should be examined by a medical practitioner, and they can apprehend and convey a patient that is absent from a facility without authorization. So it's actually detailed. Their duties on apprehension is detailed in the Act in Section 90, subsection 1. And this includes they need to take reasonable measures, including when they are entering a premise and or using physical restraint to apprehend and convey a person. They are to inform the person of the reasons why they're apprehended and of their rights to obtain legal counsel and facilitate access to counsel for the person. They have the role of conveying a person to a facility as soon as possible using the least intrusive means possible. And they are to stay with the person or arrange for another person to stay with them until a designated facility or other location or an authorized person accepts custody of the person being conveyed. So remember, RCMP have ability to apprehend and convey a person, whereas the other authorized person that we talked about is can convey a person only. So again, on other authorized person is Medevac personnel, including emergency medical services providers. But not all people need to be accompanied by RCMP. So as we said, this may escalate the situation. So where it's considered safe, Medevac personnel, including EMS providers, can convey a person to a health facility for examination. And remember, they can only convey.